Hello everyone, how are you all? Thank you so much for joining our today's session and welcome everyone to First Aid AMC Clinical. I am Dr. Arshan Ahmed. I will be the coordinator for your 5 months AMC Clinical course. So as you know that today is our free trial session and we take this class almost every 5 months. Okay, so usually this is how we start our course. We start with the most important topic, which is the psychiatry. And also like the most, I can say that this is the most important part where candidates doesn't know anything because most of us did not go through too much in psychiatry in our medical universities or schools. So AMC knows that and they gave a lot of scenario regarding your psychiatry. But it's important to understand that psychiatry plays a vital role if you are going to pass the exam or not, because it shows your approach to a patient. Other topics like let's say medicine, pediatrics, those are also important, but the approach, how you are approaching a patient and how you are managing a psychiatric patient, it shows that how good you are. So it's really important to get a good idea on this psychiatric basic. So tonight we are going to discuss about this basic actually. Before we start, I just want to know that if we have got this class live on the Facebook or not. Give me 1 minute. I'll just make sure that then they can hear me. All right. Those who are in the Facebook live, do you guys hear me properly? And please understand that normally we don't take class on Facebook Live. This is just for the trial session because many candidates doesn't know how to join a Zoom session just for that. So if you can just write it in the chat box or in the comment section, please, those who are in the Facebook Live, that are you guys able to hear me properly? Yes, good. So let's start our tonight's class. Those who are in the Facebook, please try to join the Zoom class from the next one because we are going to have a 2 weeks free session starting from 21st of August. So please try to join the Zoom so that I don't need to go in two places. Okay. And joining the Zoom sessions are super easy. And also we have got 500 participants can join at the same time in this Zoom class. So you can join and it's really fine. Okay. And in that way, we can interact more clearly without interrupting each other. Now, tonight's class is mainly on psychosocial history, which is the basic of psychiatry, I would say. If you want to know that I want to be a good doctor, you want to know that how to take a psychosocial history. And the first and foremost part of taking a psychosocial history is that how is your approach? Are you going to be in like a usual candidate which is going to appear the exam and sounds like a normal candidate, or are you going to be an exceptional candidate who doesn't sound like someone who just read a note or who only read the Karen notes? So you need to think about that. Well, there are 16 candidates or even more than that in a clinical exam. And if you sound like most of the candidate, how the examiner will understand that this candidate is better and he or she can pass this station. So if you want to pass psychiatry, you need to be a little exceptional from others. And how we make ourselves exceptional, the history is pretty much same for everyone. Everyone knows how to take a history from psychiatric patient. But the initial part, that how you start your conversation, how you respond to a patient gesture, patient history, or sometimes even patient is not talking to you, just looking at you or looking at the ceiling or wall. So how you are going to approach these things in the exam, that matters a lot. And please understand that AMC clinical exam is not about how much prepared you are or how much knowledgeable you are. Lots of you are, even in your country, you are already in a residency program, or maybe you are already a specialist. So even though you are a specialist, you have to play like a junior doctor in AMC clinical. You can't play like how you used to see the patient in your own clinic or hospital, because it's different in Australian perspective. You're going for a MC clinical exam and they think that you are a junior most doctor in the hospital or in the general practice. So you have to act in that way. You have to follow the protocol. Where needed, you have to involve your senior and also involve the specialist in some serious situations. So you have to follow the protocol. You are not going to do everything. Your job is to just take a history from the patient and make sure this patient doesn't die in front of you. Okay, so that's important. Now let's start. Okay, lots of talking. Now, for psychosocial history, the first thing that we need to learn, that how to approach our patient and how we take confidentiality statement. For any psychiatric assessment or history, confidentiality is must, which means that you have to give reassurance to a patient that, well, whatever we are going to discuss today, it's confidential. Now, there are two approach. One is conventional approach, and another is a kind of alternative approach, or you can say that I like in that way. So, and not only me, actually, the examiner also likes. Like if you give confidentiality statement in a much broader way so that patient understand and you can open up the patient. Patient is a closed book in case of psychiatry. You have to try to open that patient. And how you're going to open her up, it depends on your confidentiality. All right. Okay. Let's see. Just give me 1 minute. Is everyone able to join? Yes. Cool. Now, starting with your confidentiality, the conventional approach is that you greet with the patient, say that, hi, this is Dr. X, one of the doctor here. It's very nice to meet you. Let me assure you, John, that whatever we are going to discuss today, it will be between you and me unless it is harmful for you or others. So that's conventional approach, which everyone, I would say most of the candidate will use this one. Now let's say that a patient is a depressed patient and he or she is not maintaining any eye contact in front of you. And when you go into the room, it could be an online room or could be a face-to-face room, whatever it is, it's the same approach. So you can already you can appreciate that this patient is a psychiatric patient. And without anything, you just go in there and you start talking without trying to read the patient. You have to read the patient first, that, well, this might be a case of depression, or at least I know this is a psyche patient. He seems to be depressed. Okay, that's called just a general appearance. You already know about it. Now, this is one approach, and a greater approach or the alternative one is this one. Say that, always be polite with this patient. Say that, hi, this is Dr. Arshan, one of the doctor here. John, I can see that you are really sad. I'm really sorry for that. But I want you to know that we are here to help you. You can tell me what's going on or whatever making you really stressed. I want you to know that right now we are here with you and we'll be doing everything possible to make sure you become comfortable like before. But if you are not ready to talk now, that's okay. I'll be here sitting beside you. And whenever you feel like talking, then, then we'll talk. But I want you to know that whatever we are going to discuss today, it's confidential. I'm not going to share it with anyone unless it is harmful for you or others. Now you decide which one is better, right? And sometimes because there is a lot of candidate who will use the same sentence again and again, and sometimes role player will not open up. Even if you give the confidentiality statement just a conventional one, maybe role player, no, I'm not going to give this to this examinee. I'll be silent. Okay. So sometimes this happen. If they don't like you, they are they can actually not open up with you. So they can totally sit there and don't open up. So that's permitted. If they don't like you, they will not talk to you, especially psychiatric patients. So you need to make sure that they buy you. So you have to be very polite. You have to be, you have to know that how to talk with this particular patient. Someone who is having mania, who is very euphoric, your approach will be different from this person who is depressed. All right, so different approach based on patients, that's really important. Just one quick question. For those of you who is trying to join the Zoom session, is it showing that you are unable to join the Zoom because it's full? If it's something like that, especially for anyone who it's showing it's full. Okay, that's the one thing, because I guess many of the other candidate is also trying to join the session, but they are not able to. Just excuse me just for 1 minute, guys. I think I know how to fix that up. Okay, please bear with me. Just a minute. All right, guys. So don't worry. So if someone is not able to join, I don't know why it's showing in that way. Maybe something like maybe somehow it's been missed. Okay. So just ask your friends to join the live session in the Facebook for the moment. From the next session, especially in the free 2 week session, I'll have a look at why you guys are not able to join, because we actually had a 500 capacity for this Zoom session. I don't know why it's not allowing me to join. I have to contact with the Zoom teams maybe. All right, so don't bother. So let's continue. If anyone is not able to join, ask your friend or any of your study partner. This class is also live in the Facebook. So just in our First Aid AMC clinical group, the class is also in live. So ask them to join in that way for the moment, okay? So that we can continue the session. Now, so we have been in the confidentiality statement. So once you gave the confidentiality to the patient, sometimes then patient will start to open up that, doctor, I just don't want to live my life. I want to kill myself. Okay, so that's the important moment that you know that this is a psyche patient and this patient probably is a suicidal patient or at least a depressed patient. Now you start. After that, you will follow your psychosocial history format. The format is same for everyone. Sorry, so can you quickly go through the alternative approach of confidentiality? I think we just discussed about it, Dr. Farah, that how to start with a patient with the alternative approach. So in this case, you need to greet the patient properly and politely. So say that, hi, this is Dr. Arsham, one of the doctor here. I can see that you, and now it depends. If the patient seems sad to you, then you say in that way. If patient doesn't seem sad, then you will not use this term. So we are discussing as a depressed patient in here. So say that, and you should lower your tone also when you are talking with a depressed patient, as if you are empathic. You have to show that. So say that, I can see that you're really sad. I'm really sorry to hear that, or I'm really sorry to know that. But John, I want you to know that we are here to help you. And you can tell me whatever going on and what's making you really stressed. I am here with you unless you're ready to talk. I want you to know that we are here with you in every possible aspect, and we will try our best to manage you to make yourself comfortable like before. You don't need to talk to me now if you're not in the mood, but I'll be here sitting just beside you. Whenever you are ready to talk, just let me know, and then we will go forward. So it comes from your mind, like there is no particular thing which you just need to memorize. It should come from your mind that, well, I need to talk in this way in this with this patient. So it is how you express yourself and how you show your empathy to a person who is depressed. Once the patient says that, well, doctor, I can't, I want to kill myself, or I can't bear this pain at all. It's, it's, it's totally destroying me. So something like that patient will say. Once you know that something is wrong with this patient, then you follow your psychosocial history. Okay, so start with this format always. But if patient, even if, when you say that, if you like, I'll be sitting here with you until you are ready to talk, patient is not saying anything. It happens, like depressed patient has slow monotonous speech. They just say or answer whatever you ask. So it can happen, like they will never ever say that I am ready to talk. So are you going to sit there for 10 minutes? No. So what you're going to do? So in those situations, when you gave a long confidentiality statement, still patient is not opening up, you have done your part. Now you start asking questions. So John, would you please tell me how you are feeling right now? How is your mood? Okay, so that's your first question. So mood, sleep, and appetite. Then next we ask suicidal ideation, followed by we go for perceptual disturbance like hallucination and delusion. So start with the mood question first. So say then how is your mood these days? Patient says low. The next question we should ask is that anytime did you ever feel that your mood is really high? Why we ask that? To rule out bipolar disorder. It's really important. I have heard a lot of candidates ask the patient to score their mood. I don't feel like it's needed because it's very unusual that a patient will be able to score their mood, and it doesn't have any clinical perspective. So we don't need to actually ask a patient to score that how is your mood in between 1 to 10. It's not needed. But if you do, it's not prohibited, but I don't feel like it's a good thing. Okay, so say that how is your mood these days? If patient says low, you ask the patient, anytime have you noticed that your mood was really high, which is not usual? So that's how you rule out bipolar disorder. The next question is sleep and appetite. So how is your sleep and appetite? Now, again, it depends. If you get a positive finding, you go in detail. So patient says, I can't sleep at night. So what you should ask, are you going to your next question? No, you're going to find out what's the problem with the sleeping. So, Will, can you tell me since when this is happening? Do you feel difficulty in going to sleep? Or do you wake up early in the morning? Or do you get multiple breaks in between your sleep? Three things are important sleeping question. If someone says that they cannot go into sleep, or that means they are having trouble initiating sleep, that's probably going with anxiety disorders. If someone says that they are having early morning awakening, that's going with the depression. Someone says that they are getting multiple breakups during sleeping. So they just get up in the middle of the night. Why they are getting up? Because most likely it's they're getting some nightmare. So that's going with PTSD. All right. So as you understand, so a lot of things you need to find out. If you get a sleeping issue, you need to find out, are you having trouble going into sleep, or do you get early morning awakening, or does your sleep get break up multiple times during your sleep? If sleep is breaking up multiple times, ask the patient directly. So do you get a lot of nightmares, John? So that's very important. Nightmares, if it is nightmare, we need to rule out PTSD. That means post-traumatic stress disorder. Okay. So sleep and appetite is done. The next thing is suicidal risk. It's a very, very important question. Someone coming to you for the first time with a psychiatric history, the first thing that you need to make sure that is this patient safe enough to go back to home. So safety assessment is really important. So even if you forget a lot of things, but you can't forget the suicidal assessment in the first psychiatric history in anyone in your life. It means if you're in a hospital, you have to make sure that this patient is safe. So how we assess safety? We ask suicidal risk. So we ask a patient, John, do you think your life is worth living? Patient says, no, doctor, I don't feel like I'm worth living. What do you say next? Do you ask next question? No, you say, sorry. I'm really sorry, John, that you're feeling in this way. John, do you have any passing thoughts of harming yourself or others? Yes, doctor, I feel like hanging myself and just kill myself. I don't want to live this life. So now you got that this patient having active suicidal ideation. The next thing, if patient having active suicidal ideation, the next thing you need to find out, do you have any definitive plan in your mind that how you are going to commit suicide? So active suicidal ideation, next question is any active plan? The next question is that have you ever tried suicide before or any previous suicidal attempt? If you want, if you have some time, you can also ask one another question that currently, do you have access to any weapons? So these are the 5 questions that we ask for suicidal patients. But if patients say, Do you think your life is worth living? Yes, doctor, I feel my life is worth living. Then you don't need to ask these four questions because already you know this patient is not suicidal. All right. So why I'm showing you every possible way is really important because we have been taking mock test to the candidates who are prepared to appear exam. And I have seen that even if they are really good candidate, what they are lacking in the, because they are first time candidate, they are lacking this response to a patient. When a patient says that I don't feel like living, and what, because of the exam pressure, what they are doing, they are asking a next question without saying anything about this patient. What he just said to you, he said that he doesn't feel like living, and your next approach is, do you have any passing thoughts of harming yourself? So you missed a vital communication in here. AMC looks for this communication. If you don't have enough communication ability, they will not pass you, even though you cover everything. So the communication is just not only that how good you are in talking to a person whose main language is English. Well, Asian people usually they have an accent, and most of us are Asians, right? And that's fine. We will not have an accent just like someone who born in English countries. And they know that, and that's perfectly fine as long as you are talking fluently. Okay, as long as they can understand you. And remember one thing, most of them understand you because they are doing it in a lot of long years. They are participating as a role player, so they understand your language, they understand your accent, so don't bother with that. If you can talk fluently, that's fine. The next thing is this approach. Whenever patient says something which sounds like sad, now for this patient, he says that he doesn't want to live. You should say, I'm really sorry, John, that you are feeling this way. Don't worry, I'm here to help you. Okay, so say something so that patient knows that, well, this doctor is not only just want to pass this station or want to just ask question and then he wants to go and have a coffee. Okay, so not like that. Once you are done with the suicidal assessment, then you go for more psychosocial histories. So say that, John, I'm going to ask you some screening questions that might seem quite silly and strange to you. Is that all right with you? Yes, doctor, that's fine. Okay, now you ask hallucination and delusion question. Say that, do you see, feel, or hear things that others don't? So what you are asking visual hallucination. For feeling, tactile hallucination, and hearing is the auditory hallucination. So that's your perception in MSc. We will just discuss after this psychosocial history that how to take or how to explain mental status examination to the examiner. So MSc is super important for exam. One of the part of MSc presentation is this perception. So you ask just one question, do you see, feel, or hear things that others don't? Okay. So if you don't say this line, initially patient most of the time say that, what is this bullshit, doctor? So do you think I'm a crazy person? Why I will see things? What do you mean? So now you will get surprised. And then you will start startling and you will just say, oh, no, nothing. So this happens, like a lot of candidates I have seen that whenever you say something in their, just directly in their mouth, and they become surprised and they become confused then. And then the whole station, they just don't know what to do because they lost it at that time. So do not get this sort of confrontation. So just avoid it by saying these things. The next question is delusion, which is a part of thought content in MSc. For delusion, we have RCGGP. So what is RCGGP? R is delusion of reference, C is delusion of control, G is delusion of grandiosity or grandeur delusion. Another G is delusion of guilt, and P for persecutory delusion or paranoid delusion. Okay, so delusion of reference, delusion of control, delusion of grandiosity, delusion of guilt, and persecutory or paranoid delusion. So you need to ask this question. Especially if it's a schizophrenic patient, you need to ask this full RCGGP. But what if it's a depressed patient? Then you don't need to ask all of it. Just depressed patient, most of the time they feel guilty. So you want to rule out delusion of guilt in those patients. But you don't need to ask the full RCGGP in those patients. So depending on the patient presentation, the delusion question will differ. So what are the questions? So first question is, do you think someone is spying on you or trying to harm you? This question is for paranoid delusion or persecutory delusion. So patient with paranoid delusion, they feel like someone is spying on them or someone is trying to harm them. The next question, do you think someone is controlling you? That's delusion of control. Do you think people are always talking about you? So some of the schizophrenic patients, they feel like people in the street are talking about him. Everything is referring to him. So that's called delusion of reference. If they feel like everyone is commenting on whatever he's doing, the people are talking about him in the street. So that's delusion of reference. Do you think you are guilty? That's delusion of guilt. And do you think you have some special power? That's delusion of grandiosity. Delusion of grandiosity is specifically present in a mania patient. Not only mania, but schizophrenic patient can also have delusion of grandiosity. But most commonly, mania patient usually have it. Delusion of guilt, almost every time it is present in a depressed patient, severely depressed patient, and others, usually all the time, you will get it in schizophrenic patient. There are 2 or 3 others delusion question which you ask it if it's a schizophrenia patient. So you say that, do you think that someone is inserting or withdrawing thoughts from your mind? So that is thought insertion and thought withdrawal. That is also a part of delusion. The next question, do you think your thoughts are being broadcasted to TV, newspaper, or radio? That is called thought broadcasting. So thought insertion, thought withdrawal, and thought broadcasting, these are also present in many schizophrenia patients. Why it is important to know this name of the delusion? Because when you present MSc to the examiner, you have to say that this patient having delusion of reference because you have got this finding. This patient having delusion of grandiosity because this patient feels like he has got some special power. So that's why it's pretty important to know that what is the specific delusion this patient is having. Next, we ask insight, judgment, cognition. So for insight, the question that we ask is, do you think you need some medical help? Patient who have insight, they say, yes, doctor, I think I need medical help. Schizophrenic patient or mania patients will say, no, I don't need any help. I'm perfectly fine. Then judgment. One question, if there is a fire in this room, what you are going to do? Or some other candidate, they also ask in that way, if there is a snake in this room, what you are going to do? It's totally fine, whatever you ask. But you need to ask that if there is a fire in this room, what you are going to do? So patient who has intact judgment, they will say they will run. Those who doesn't have intact judgment, they will say, well, I'll stay here. Fire cannot touch me because I am the messenger of God. So they don't have judgment. Okay. Cognition is this patient oriented to time, place, and person? So that's why you ask that, do you know where are you at the moment? Do you know what is the date today? And do you know who I am? So time, place, and person. These 3 questions is for cognition. So insight, judgment, cognition, that's your 3 questions. And psychosocial history is not finished if you are not asking heads question. Now, heads has a lot of discussion about it, but We don't need to go through the detail because only the important part of hits that we usually ask to a patient is home situation. So this H is for home situation, E for education or employment. So we ask about, so do you study or work? And is there any stress at your university or at your work? And we ask about the home situation. Is there any stress in your home? Are you a happy family? Who lives with you at home? So stress at home, stress at work, that's very important to find out. A for activity. So people who have depression, they lose interest with the things that they used to enjoy before. So you can just ask that, do you still enjoy things that you used to enjoy before? It's only important in patient with depression, but even if you get some time, you can ask it to anyone, but it's not needed. So don't bother if you're running out of time. So that's activity. Also, sometimes we ask about like, do you have any particular interest or hobby? Okay. D for diet. So we ask about that, are you eating and drinking well? Are you having a healthy balanced diet? That's also not needed in this case. So don't ask this activity or diet if you are running out of time. 2S is one is especially the social situation. We ask about stress, we ask about sexual. So these are S. Also, these are not important. Only thing that we ask from heads is home situation, work situation, and support. So ask that, John, how's your home situation? Who do you live with at home? And is there any stress at your home? Yes, doctor, I'm fine. How about work? Do you study or work? I work, doctor. Is everything good in your work? Do you have any excessive stress? No, doctor. Any financial issues? No, doctor. And do you have enough support? Yes. So this is all that you need to ask to a patient in terms of hits. The next part is SADMA. SADMA usually it's mainly for your smoking. Then you ask about alcohol. Then M for medication and allergies. Don't bother with all these things. Just ask about, do you smoke or drink alcohol? Any other recreational drugs that you are using? Okay, just that is fine. Then ask about past medical history, any past history of mental illness, and is there any other medical condition that you have? You can ask medication history, that are you on any medication? Always we try to rule out some organic causes. So organic causes, if you want to rule out, just to rule out hypothyroidism, head injury, and any recent infection. These three things can mimic acute psychiatric problems. So is there any recent change in your weather preference? That's for thyroid disorder. Any head injury recently? Or do you have any flu-like illness? Just three questions that will show that you are also aware of this thing, that medical illness can mimic psychiatric problem. And lastly, just finish with family history of mental illness. So in a summary, for psychosocial history, we ask, first we give confidentiality statement, followed by mood, sleep and appetite, suicidal ideation or suicidal risk assessment. Then we ask hallucination, delusion, insight, judgment, cognition, heads, SADMA, rule out organic cause, past medical history, medication history, family history. So in your head, you just remember these steps, okay? And that cover almost every psychiatric history. All right. So it's very important that you know how to take this history because it will be needed in every possible psychiatric history they are asking. Okay. So any question with the psychosocial history, guys? Now, sometimes we might need to add questions depending on the presentation. Like if it's a depression patient, we will ask all other Msc caps question. Today, we are not going in detail about it because depression is not a part of our today's class. But remember, if it's a depression patient, you need to ask all the Msc cap question. That means you need to find out mood problem, loss of interest, sleeping issues, loss of appetite, any feeling of guilt or worthlessness. You need to find about loss of concentration. Okay, you need to find about slowing down on things, which is psychomotor retardation. So all the MSICH cap question you need to ask in depression patient if that is your history. If it's a mania patient, then we follow Dick first, mnemonic. We'll discuss everything in our other psychiatric classes. So what I'm trying to say, depending on the patient presentation, we ask some other question just related to their condition. But for every patient, this format is always the same. Psychosocial history, this format will be there. You just add or delete things based on the presentation. So doctor, in case of sleep and appetite assessment, do we have to ask all three questions if we get the answer to one of the questions already? Yes, we should ask it. If you, especially for sleep question, we ask, if there is a difficulty in sleeping, you ask these three questions to everyone. The recording will be on the Facebook group and also will be in the YouTube, but the slides will be only given those who are joining our course. Okay, but slides we don't give it generally to anyone. It's usually in our software only. Okay, so the next important one is the Msc format. Those who are in the Facebook, do you guys have any questions? Yes, Dr. Saba, only in depression you ask M such caps, otherwise you don't need to ask it. The next one is aseptic J3R. I guess a lot of you heard about it. So aseptic J3R is how we present MSc to our examiner. Now it's really important to follow this because examiners are super picky in this aspect. I don't know why, but they don't like that you miss anything in MSc. All right, so make sure you know it perfectly. In aseptic J3R, appearance and behavior is that how the patient looks like to you. Is there any abnormal behavior he's having? Like some patients, they tend to look into the ceiling as if someone is trying to communicate with them. Okay, so some people, they don't maintain eye contact. Some people, they become really aggressive. So whatever you see in a patient, you just include that in this appearance and behavior. That's your A. S for speech, E for emotion, which is assessed by asking the mood question, T for perception. Remember the hallucination question that we asked? Then two T. One T is thought form, another is thought content, I for insight, C for cognition, J for judgment. We already asked everything. Remember in the psychosocial history, we asked mood, we asked perception, we asked thought content, which is the delusion question, insight, cognition, judgment, we already asked. So right now you already know half of the MSc. So let's discuss it a little bit. And the last, these three are, is one is risk. So how much risk this patient is, mild, moderate, or severe. Rapport. Rapport means that are you able to maintain a good rapport with this patient? How we comment on that? That if the patient is talking to you politely and answering your questions appropriately, that means you are able to maintain a good rapport with the patient. If patient is not talking to you or even very angry with you, that means you are not able to maintain a good rapport with the patient. And remember, it's not your fault. Some patients are like that. They will not answer your questions. They will be angry with you and they will angry with everyone. So that doesn't mean that you will fail the case if you are not maintaining a good rapport. You just say what you find. And reliability is the history given by the patient is reliable or not. Because most of the time we say it's not reliable if it's a history coming out from a schizophrenic patient or a manic patient, because their history is not reliable. They say whatever they are feeling. Or what we need to do in unreliable history, we need to take a collateral history from someone who already knows this patient. Like it could be a neighbor, could be relative, could be their parents. So whoever knows this patient, we need to also take a collateral history from them. Now that you know the aseptic J3R, we'll just discuss each and everything, that how we are going to approach it. Obviously, remember one thing, that your history is pretty much same that how we discuss the psychosocial history. Nothing much to add. There are two type of question comes in exam in this way. One, in the task they say that take a psychosocial history, give your diagnosis and differential diagnosis. In that case, aseptic J3R is not important, because your task is not to present MSc to the examiner. If it is just a task of full psychosocial history, then you follow the previous discussion that we have just done. That means you need to take the full history and then give the diagnosis and differentials. Another type of question is present MSc to the examiner. So first is take history from the patient and present MSc to the examiner. In that case, because you have two tasks and you will need some time to present MSc to the examiner, and MSc doesn't include home situation, past medical history, family history, those things, even if you miss it, they are not going to fail you. As long as you properly you discuss about the MSc and present it to the examiner, you are fine. That means in case of MSc presentation, even if you don't bother with these heads, SADMA, past medical history, organic or family history, this part, they are okay. But I would say that just give a wrapping at the end, that just don't finish with cognition question. Just ask that, is there any medical condition you are having, any mental illness, any family history of mental illness? So just wrap up the history so that at least they know that you finished the history. Okay, but you don't need to ask the full head SADMA like we do in psychosocial history. When you present MSc to the examiner, first give a brief introduction of the patient, and then one by one you say according to the aseptic J3R whatever finding you have got. And that's why we need to write aseptic J3R in a paper which will be provided by the AMC. If you are in the online examinee, then you can put a paper in front of you and also a pen. If you're going for a face-to-face, then they will give it to you. So whenever you get a MSc presentation case, just before starting your questions to the patient, first greet the patient and just say that, please excuse me for a moment, John, I'm just writing a particular thing so that I can assess you better. Okay, then you write aseptic J here in the paper, and then you start your questions. Okay, and some people just go inside and they start writing something without introducing them with the patient, and that's wrong. So there are ways to communicate, and many candidates actually doesn't know that, and that's also not their fault because no one discussed this thing. Even like there is a lot of course who will never ever talk about these tiny details which are important. Okay, because how you will know this thing if you are not practicing in Australia? There is no way. And things are pretty different from how you practice medicine in your country and how everyone practice medicine or psychiatry or anything in Australia. So this thing you need to learn. And these are not very hard also. You just need to know that I should do this. And I should know that, well, before writing anything, I need to introduce myself with the patient, excuse myself from him, and then I can write. Okay. Once you've done that, then you will start your question. Question is how we discussed now. Once you finished it, then you need to present MSc to the examiner. So how you will do that? Start in that way, dear examiner, I would like to present the mental status examination of my patient, Mike, a 35 years old patient found by his partner trying to hang himself in the garage. So you will just copy whatever it's written in your stem. So just a brief summary that, well, this is a patient who is a 35-year-old. His name is Mike, and he's found by the partner trying to hang himself in the garage. In terms of appearance and behavior, so in appearance behavior, these 5 points we usually say. One, that is he dressed appropriate to the weather? Is he well groomed or unkempt? Is he cooperative or not? Is he maintaining eye contact? And is there any abnormal body movement or posture? In terms of abnormal body movement or posture, there are a couple of points that you can remember, that if the patient is sitting in a stooped posture, not maintaining any eye contact, probably this is a depressed patient. Some patient who has anxiety disorder, they will show that they will move their hand kind of fidgeting. So frequent fidgeting means anxiety disorder. If patient seems very restless, not sitting in the chair, just like very restless and agitated and loud voice, most likely that's a manic patient. If it seems that patient is distracted and responding to some unseen stimuli, like whenever you are asking some questions, you see that this patient is looking at the ceiling as if someone is talking with him. So what he is doing, he is responding to some unseen stimuli which we can't see. That is positive in schizo patient. So these are the things that you need to talk about. Not only it's not restricted only to this thing, whatever you will find out in a patient, you should comment. And this appearance behavior is really important, that there is a specific marking for that. Okay, so please make sure you don't forget appearance behavior. Whatever patient showing to you, explain in here. So say that he is dressed in terms of appearance and behavior, he is dressed appropriate to the weather, he is well groomed, he is cooperative and maintaining eye contact, and there is no abnormal body movement or posture. Okay, if you get depressed patient, you might get something like that, that in terms of appearance behavior, he is dressed appropriate to the weather. He seems quite gloomy and sad. He is well groomed and cooperative, but he's not maintaining eye contact with me. And he was sitting in a stooped posture. Okay, but there was no restlessness or agitation or no fidgeting, and he was not distracted. So in MSc presentation, we always give positive and negative findings, and that's a very good way to explain it. Examiner love it. Some candidate, because they don't get enough time at the end, they just say the positive finding. It depends that if time is there, try to explain both positive and negative finding. It's very good. Then speech. In terms of speech, his speech is normal in rate, volume, and tone. So three things we assess. Is it rate means some patient will talk in a normal rate, or some patient will be talking in a pressured way. So they will talk as if a train is running. Okay, so something like that. So pressured speech, it means there is increased rate in their talking or speech. Volume, some patients volume and tone can be high, some patients volume and tone will be low, so it depends. So if his speech is normal, then say his speech is normal in tone, volume, and rate. If it is a depressed patient, most likely you will get a slow monotonous speech. If it's a manic patient, you might get a rapid pressured speech. Slow monotonous speech means that patient will be very slow, and trust me, depressed patients are quite slow, and you will be killing yourself in the exam that please be fast, I'm running out of time, man. So something like that will happen in your mind. Okay, but don't express that. That's important. So volume and tone, usually slow monotonous means patient will be very slow, and monotonous means that whatever you ask, patient will give you a yes or no. That means in one word, they will answer your question. Okay. Sometimes in depressed patient, they talk in a way that they are taking pauses in between. Like you ask that, how's your sleep and appetite, John? Patient says, my sleep. And there is a pause. Oh, doctor, I'm not getting sleep. So something like that. Trust me, it kills. Okay. In exam, you don't want to get this sort of patient, but unfortunately, severe depressed patients are acting in that way, and it kills a lot of time. So you have to be very fast in your history. So that's slow and monotonous speech. And another is rapid pressured speech, which means that manic patient will be talking constantly without giving any break. So that's rapid and pressured, and they will be very loud. Again, sometimes we also try to find out, is there any disorganized speech, which you will get in psychosis patient. If sometimes mania patient will not answer your question appropriately or spontaneously, and depression taking pauses in between. So whatever you find, you just add it in your speech. Then come to the emotion. In emotion, we talk about two things. One is mood and another is affect. Mood is when you ask a patient how you are feeling right now, the patient says, I'm feeling very low, doctor. That's mood. So according to the patient, his mood is low. Now the affect means that what an examiner or what you as a doctor looks into this patient. Do you think this patient also looks sad, as if patient is saying? Or sometimes in schizophrenia patient or manic patient, when you ask, how is your mood? Patient, not mania, schizo patient, when you ask, how is your mood? Patient say, yes, I'm fine, doctor, I'm okay. But this patient is having hallucination, delusion. So his affect is not normal. His affect is disturbed. Okay. So if you get a depressed patient and patient say mood is low, and you see that patient is actually having feeling very sad and gloomy, then you say, according to the patient, his mood is low and the affect that I have observed is congruent with his mood. Okay. Now, let's say it's a schizo patient. Patient say mood is normal, but you find out that it's not normal, it's disturbed. Then you say, according to the patient, his mood is normal, but the affect that I have observed seems like he is disturbed, so it is not congruent with his mood. Okay, so in this way you have to explain. So that's emotion. Then comes to the perception. In terms of perception, this patient having auditory hallucination because he can hear God. Okay, so whatever finding you will get in terms of perception, you have to say it here. So if it's auditory hallucination, you say it. If it's visual, you say it. After perception, then there is 2T, thought form and thought content. The thought form is important, and many of you get it wrong in the exam. Thought in a normal person, or even if it's a mental history patient, if they are talking to you appropriately and they are answering your question spontaneously, their thought form is linear. Linear means that they are able to understand you and they are talking in a just like a normal person. So that's linear thought form. What are the other abnormal thought form? Some patient can have loosening of association. That means whatever they are talking, you can't understand it. So kind of disorganized speech, and that is what we find out in schizo patient, they will have loosening of association. That means in every sentence they are telling to you, you can't understand the meaning of it. So loosening of association. We'll discuss it by some example later on, don't worry. The next one is tangentiality and circumstantiality, which is also found in schizo patient. Tangentiality, circumstantiality, that is a part of loosening of association also. So tangentiality means that you ask the patient that, how are you feeling, John, today? And John says, Oh, doctor, my name is John. My grandfather is dead, and well, my mother is still alive. But I need to go to watch this movie, doctor. Remember that bus? Bus was really nice to ride. Oh, that movie was really good. So what's happening? Every sentence this patient is saying, there is no association. Whatever they're talking, nothing actually means anything. So that's known as loosening of association. And for something, if someone doesn't come back to your question, like you said, how you're feeling now? Patient did not answer that question, but he told you a lot of other information. So if patient never answer your question, that's tangentiality. But when you ask, how's your mood these days? Patient says a lot of information, but at the end, he says that, yes, doctor, I'm feeling okay. So that means patient at least answered your question, and that is a part of circumstantiality. Okay, so that's important to understand what is tangentiality, what is circumstantiality. These are found in schizophrenia patient, but I have never seen in exam these sort of cases coming in exam, because in exam they need to give you information. If someone is answering in that way, how they are going to give you information? So in exam you will never find this sort of patient, but in normal situation you can get it. There is another abnormal thought form which we call concrete thinking. That means patient will not understand the literal meaning of your question. So like you ask, how do you feel? And patients say, I feel with my fingers and toes, doctor. So, so this is how they answer. That is called concrete thinking. It's not important, so don't bother. The thing next is flight of ideas. Flight of ideas and loosening of association. These are important because it can get mixed up in the exam. Flight of ideas will be present in mania patient always. Schizophrenia patient can have linear thought form, or sometimes they can have loosening of association. But mania patient always have a flight of ideas. Now, flight of ideas means that they are jumping from one topic to another. But there is still a little connection between each and every sentence patient is talking. How we differ it from loosening of association? There is no association link between each sentence patient is telling to you. But in flight of ideas, patient is jumping from one idea to other, but there is still a small link. Okay, now we will discuss about flight of ideas and loosening of association. Let's have a look that this is example of flight of ideas. So linear thought means there is no example of linear thought. Linear thought means that if you ask, how are you feeling right now, John? Patient says, I feel okay, doctor. This means that patient is appropriately answering your question. That means their thought form is linear. So normal thought form is linear thought form. Now, flight of ideas, see this one that they're jumping from one topic to another and rapid shifting in their conversation. So this is one of the example. Oh, I love that movie. I'm going to watch a movie with my mom, and my mom adores me. Now, as you can see, there is not much association in each of the sentence, but what you can see, there is movie in here, there is movie in the next sentence, there is mom here, there is mom in the next sentence. So that means there is still a link between each sentence patient is saying to you. In loosening of association, there will be no link. Like this is another flight of ideas. My father sent me here. He dropped me in a car. The car is yellow in color. Yellow color looks good on me. So each sentence has some linking, right? That is what we call flight of ideas. But patient is jumping from one topic to another. Look at the loosening of association. Ah, I went to the market. I should read that book. When did you buy this dress? It's a lovely evening. I should go for a walk. I feel like having a chocolate. So is there any association in each of the sentence patient is saying? No. So that's what we call loosening of association. Loosening of association will be found in schizophrenia patient. Flight of ideas will be found in mania patient. Cool. Any problem understanding that? I guess you should not have any problem. So after thought form, then the next is thought content. Thought content, usually you will include delusion. Whatever delusion you find out from a patient, you will add it here. Sometimes there are two other things which you can add in thought content. If it's a overvalued ideas, like if it's the anorexia nervosa or bulimia nervosa patient, or a patient with body dysmorphic disorder, these patients will have overvalued ideas about their body image. So if a question comes with this topic, anorexia, bulimia, or body dysmorphic, then the overvalued ideas that they are having a thought or distorted image of themselves, that will be included in their thought content. For OCD patient, obsessive compulsive disorder, this obsession is also a part of thought content. Okay. And then remember the aseptic J3R. So ASEP TTIC J3R. So you talked about appearance, speech, emotion, perception, thought form, thought content. Do not mix up these two things. Thought form is linear or loosening of association. Thought content is delusion. A lot of candidates mix up this thing. Insight, judgment, and cognition. We already know how to ask it. And then 3R. 3R, how much risk this patient is having. If a patient having active suicidal ideation, if a patient having active hallucination or active delusion, they are high risk patient. Okay, if a patient doesn't have any of it, they are mild to moderate risk. Rapport, are you able to maintain a good rapport with the patient? And reliability, is the history reliable or not? And if it's not reliable, then you need to take a collateral history from a family member. Now, I want to just say that, let's say we have got a patient who is depressed. And that patient, we are going to explain to the examiner whatever MSc presentation we have found and how we should do that. I'll just show it to you. So start in this way. Dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old patient found by his partner trying to hang himself in the garage. In terms of appearance and behavior, he is dressed appropriate to the weather. He is well groomed, but he looks very sad and gloomy to me. He was cooperative, but was not maintaining eye contact. There was no abnormal body movement or posture. In terms of speech, he was talking in a very slow and monotonous way, but there was no rapid pressured speech or disorganized speech. In terms of emotion, according to him, his mood is low and the affect that I have observed is congruent with the mood. In regards to perception, he did not have any hallucination. Thought form was linear. There was no loosening of association or flight of ideas. In terms of thought content, he is having delusion of guilt because he thinks that he killed his patient and that's why he is feeling guilty of murder. But he did not have any other form of delusion. His cognition is intact, but he doesn't have any insight because he feels like he doesn't need any medical help, and his judgment is poor because he just don't want to do anything if there is a fire in this room. In terms of risk, he is a high risk patient because of having an active suicidal ideation with an active delusion. I was able to maintain a good rapport with my patient, and the history given by him was reliable. It depends that if patient doesn't have insight, then we can say it was not reliable, and I would like to take a collateral history from the family member. If the task is MSc presentation, you don't need to give a diagnosis. Okay, just finish there. Clear, guys? This is how you should explain MSc in your exam also. So, any questions so far? Any changes in thought forms of depression, anxiety? Usually, no. Thought form is usually linear in depression anxious patients. So, Dr. Abdul, you say history is reliable if you see that a patient having insight and a intact judgment. Someone having insight, their history is reliable. If someone's insight is poor, then you say that history is not reliable. And Dr. Farah, if we find that the body movement corresponds to depression, do we need to go through other posture, just to exclude other disease? Like now, posture, you don't ask any question, you just look at the patient. Okay. So if you don't get something, you just say that you do there is no restlessness or agitation, no fidgeting. Even if you don't give this negative finding, that's fine. They are not going to fail you for that. Francis, can we look at what we wrote? Yes, you can wrote. That's totally fine. And you should write the findings. Otherwise, there is a high risk that you will miss something. So write the important positive finding. And then you can, yes, during presentation, you can look at your paper. That's fine. It's very unlikely, Dr. Abdul, that someone having hallucination, their insight will be intact. Very unlikely. Because the schizophrenia patient usually doesn't have insight. Critical errors in MSc presentation. Now, Dr. Azmeri, there is no critical errors in AMC clinical exam. Okay, the thing is that are you giving the key steps that is needed to pass this exam or station? There will be no critical error. You may miss something, and they're not just going to fail you for one thing that you miss. The important thing is that you can't miss positive findings in here. Your approach should be really nice and appropriate. Confidentiality, if you miss, most likely you will miss the station. And importantly, don't miss the important thing. Like someone is having delusion of guilt and you miss that. That's probably a fail. Someone having active hallucination delusion and you totally miss that. That's a fail. So this important finding you cannot miss. Yes, every psychiatric history, there should be confidentiality statement. And Dr. Saba, the mnemonic for mania is dig first, but we'll discuss about it. That's fine. Don't worry with that now. How many times I will ask question if patient doesn't want to answer? Well, this is totally subjective, Dr. Sumita, that usually in exam, if they like you, they will answer your question. If patient doesn't answer, even after asking 2 times, then you move to the next question. How do you handle a patient who doesn't answer your question? Well, that's a question which everyone wants to know. Now, it depends on your approach, actually. If your approach is good, patient will open up with you. Okay? So you have to try in different aspects. If they don't like your initial approach, then you become more softer and polite with the patient. Try to find out what's bothering him, why he's not opening up. Give the confidential statement again. Like sometimes they can miss it. So just give it twice. Okay, open her up in every possible way. Yeah, if the case from the start mentioned that he wants to end himself, yes, we should ask the suicidal ideation. That means we need to find out from the patient own term that what actually he is having. That's fine. You don't need to move to the plan and attempts. Ask that, do you think life is worth living in that way? That's fine. The mania mnemonic is dig first. Guys, I don't want to discuss dig first mnemonic for mania today because we will discuss mania later on. We won't fail if we are empathetic but could not finish the case. Well, you have to finish the case and you have to be empathic. Combination. Sometimes if you are really good, an examiner like you, if you miss a lot of important things, they can pass you. Okay, there is no hard and fast rule who will pass and who will fail. I have seen a lot of candidates who did not even finish their task, who did not finish their differential diagnosis, if still they pass the case. So it depends. Okay, let's take a 10-minute break and then we'll discuss some MSc pages, which frequently appears in exam. Okay, so let's take a 10-minute break then. Thank you all. Please do not go to anywhere. We will just start with the MSc pages, but we will take a full MSc role play session. And at that time, we'll discuss all these cases again. So we'll just go through very quickly that how the cases can come so that you can prepare in the meantime, and then we can discuss as a role play in our first 2-week session. Okay, cool. So let's take a 10-minute break then and try to remember the aseptic J3R. Thank you all. So I'm stopping sharing, but I'll come back in 10 minutes time. Okay, so let's start again. So got a question from Dr. Wafi Talukdar. If MSc video and cognition questions was not asked, what do we tell to the examiner? That's a really good question, Dr. Wafi. It means that in case of video, we will do some video in our role play session. In video cages, they will not show you everything, and not everything will be assessed. If something is not assessed, you just say that the perception was not assessed, or you say that mood was not asked. So whatever is not assessed, you will not say that. You will not say in general, just say that it is not assessed in the video. That's fine. Well, I'll discuss about the course details at the end of the class. Okay, who asked it? I think Dr. I don't know who your name, but we'll discuss about the course details, and any questions you guys are having, we'll let you ask questions about the course. That's fine. So let's just go with the MSc exam cases, which you guys need to prepare actually, and then we'll finish the class. So first question, a vet doctor brought by his wife as he was trying to hang himself with a rope since a cat died during a surgery. Very common, this vet question. So in this case, a vet is having severe depression. Why? Because during surgery, cat died on the table. And this vet doctor is trying to hang himself because he feels like he killed that cat. Okay, your task is to perform MSc and present it to the examiner. The positive point, it could be anything. We don't know what will be there. So positive points, you need to make sure what is the appearance of the patient, talk about the speech, talk about the mood. And the positive points in this case could be something like that. Patient will seem very gloomy. They can have a stoop posture, just like how I discussed the previous case. It will be same like that. And patient believes that he is guilty about killing the cat. So that's your delusion of guilt. And you should not miss it in your MSc presentation. We already discussed about this depression case, so we don't need to discuss it again. The next one, you are a HMO in ED of a major hospital, about to see a 28-year-old man who had been brought to you by the police from the street. He's known schizophrenic patient on antipsychotic, but he doesn't take his medication regularly. And sometimes he also takes ice or speed. So recreational drugs also. Take further history from him, present MSc to the examiner, and tell management to the examiner. Usually they don't ask 3 questions. That's very unlikely. But if it comes, then you have to be very quick. Okay, because it's very hard to say it. Like 3 tasks in psychiatry, almost never they ask it. But in situations they say that most likely it's a pilot case, or if it is not a pilot, you have to present in that way that it's not a pilot. So you have to be very quick with your history. Now in this case, patient was brought by a police because he was roaming in the street, and he's a known schizophrenic patient. So you have to start with your confidentiality statement. So say in that way, hi John, this is Dr. Arshan. It's very nice to meet you. I'm one of the doctor here today. How is everything, John? John says that, I don't know, doctor. I was just roaming around in the street and this bloody police just brought me here. I don't know what they're thinking. I'm totally fine. Just let me go home. So now you understand this patient is also stressed about it. So always like schizophrenic patient, they don't feel like they are having any abnormal thoughts or they are having any problem because they lack insight. So in that case, you start, well, John, I'm really sorry that police brought you here and you must be really stressed about it. But I can help you. And if you are all right, I will send you back to your home. And but before I do that, I need to ask a couple of questions just to make sure you are safe. And then I can also talk with the police that why he has brought you here. What I'm doing, I'm making a rapport with the patient. That's good, like because you always side with the patient. You don't take the side of police, right? So as a doctor, you want to make a rapport with the patient so that patient says everything to you and you can help that patient. So whatever way you want to make rapport, you have to make it. So then said John, I need to ask you a couple of questions, but I want you to know whatever I'm going to discuss it today, it is between you and me, unless it is harmful for you or others. I want you to know that this discussion is totally non-judgmental. You don't need to feel judged or blamed or ashamed for anything. If you are stressed or if you are having any trouble, please let me know so that I can help you. Okay, so start in that way and then start your other questions. So mood, sleep, appetite, suicidal ideation, and all those hallucination delusion question you have to ask here. In this case, patient's mood might be okay, sleep and appetite might be okay. They will not have any suicidal ideation. When you ask like, do you think your life is worth living? Yes. Sometimes you can actually ask another question, like any thoughts of harming yourself or others? Sometimes that prompt a quick answer from the role player. Patient says, no, why I would do that, doctor? I'm a messenger of God, and God is asking me to do good to everybody. So why I will kill someone, doctor? What you were saying? Okay, so always ask these two questions so that patient can prompt some of the information into you. Okay, so that's how you know this patient feels like he is a messenger of God. What is this? This is called, guys, if your patient feels like he is messenger of God, what he is having? Yes, so it's a delusion of grandiosity. Very good, Dr. Afrin Alice. Yeah, so delusion of grandiosity is here. So you write it in the paper where you have written aseptic J3R so that you don't forget it. Okay. Now you know that this patient having like he feels like he is the messenger of God. Now you need to go in detail about this, that the duration of it. So can I ask John that how long you are feeling that you are the messenger of God? Duration is must, because based on the duration, your diagnosis will be different. Like if it's schizophrenia, this symptom must be for more than 6 months. If it is between 1 to 6 months, that's probably schizophreniform disorder. Less than a month, it's a brief psychoactive disorder. So you need to find the duration, and many candidates miss that. So please do not miss that after today's session. Duration is important. Now you want to go in detail about this God thing. So you will say that, well, I understand that you feel like you are the messenger of God, but can you hear God? Yes, doctor. What is there any command your God is giving to you? So command hallucination is very important. If someone hears God or someone hears anyone, the next question you ask is that, is there any specific command that you are getting from the God? Okay, because sometimes command hallucination says that kill that person, kill that guy. So that's very important to find out. Then, well, can you see God? No. So this patient cannot see God, but he can hear God. So which means this patient having auditory hallucination, but no visual hallucination. Then you go in detail about the delusion question here, because this patient most likely is a schizophrenic patient. All RC, GGP, thought broadcasting, thought insertion, everything should be asked in here, because you don't know which finding they are going to give it to you. And you don't want to miss it in the exam. So ask everything. So sometimes if you ask that, do you think someone is trying to spy on you or harm you? Patient said no, but all the people are jealous of me because I'm the messenger of God. They are very jealous. That you can say it as a delusion of jealousy, but delusion of jealousy is also falls under persecutory delusion or paranoid delusion. So if you say delusion of jealousy, that's also fine. If you include this jealousy into persecutory delusion, that's also fine. But this is a delusion that if someone feels, especially schizophrenic patient feels like everyone is jealous about them, that's not normal. And you quickly ask all the delusional questions, thought insertion, broadcasting. Whatever you find positive, you just note it down. This patient will not have any insight or judgment. Their cognition is usually normal and intact. Is this patient high risk or mild to moderate risk, guys? High risk, that's right. Very good. Why? Because this patient having active hallucination, active delusion. Even if they don't have suicidal ideation, that doesn't mean they cannot be high risk. Any of the three, if it is there, then this patient is high risk. Now, in this case, your main task was MSc presentation, but because there was management in the task, you have to ask heads, you have to ask about their past medical history. Especially this patient was schizophrenic, maybe 18 months back. So you need to ask a little bit question about that. So I get to know from the notes that you had been diagnosed with a mental illness. Can I ask when it was diagnosed? And are you on any medication for that? Are you taking the medication? Patient will say no. John, I'm sorry to ask, but is there any particular reason that why you are not taking the medication? This is a way of asking question to someone who is very vulnerable and sensitive. Psychiatric patients are very sensitive. And some of the candidate, they will not follow anything. They will just say in that way, no, doctor, I'm not taking the medication. Why you are not taking the medication? So now you sound judgmental. You can never ever sound judgmental to a patient. Always like, like you want to ask in that way, but like why you are not taking the medication, but you can't ask it. You have to be very polite with the patient. So, John, I'm sorry to ask, but is there any particular reason of not taking the medication? So now patient will not feel that I'm judging him. It's very important, guys, that how you communicate, it shows how good doctor you are, and that matters a lot to pass the exam. Also try to find out the recreational drug use, because it could be a drug-induced psychosis. You don't know that. So you need to find out that when was the last time you took the ice or speed, because you want to rule out any drug-induced psychosis. So these are very important to rule out if there is diagnosis differential. If only MSc presentation, don't bother with that. In MSc presentation, so you will just present the MSc just like how I did it in the previous one. So talk about appearance, talk about speech, talk about perception and everything. Okay. Now I'm not going to discuss it tonight, but we will discuss it in our role play session, because we'll be doing role play. Then you will understand how to do that. If management is a task, management is same for everyone, especially for schizophrenic patient. If someone is high risk, that patient need immediate admission into the hospital. If you are in the hospital, then you are lucky. So what you say that this patient needs admission immediately in the hospital because he is having active hallucination and delusion. What they will do in the hospital? In the hospital, this patient will be assessed by an acute mental health team, which comprises of a psychiatrist, psychologist, and mental health nurse. Psychiatrist will start him on antipsychotic medication. Once patient becomes stable, then psychologist start CBT, and then mental health nurse will always assist the patient during his stay in the hospital. In the meantime, you need to do a complete organic workup, which is just a basic blood test. So which include full blood examination, inflammatory marker, kidney liver function, blood sugar, thyroid function, liver function, and drug toxicology in the blood and urine. You don't need to do a CT brain in everyone. Okay, so these are the basic screening which we do as part of general medicine workup. That is your short-term or immediate management. Now, sometimes patient may not want to get admitted in the hospital. If someone is high risk, then you can do involuntary admission under Mental Health Act. So you have to say in that way that this patient doesn't want to get admitted in the hospital, but because he is high risk, we need to admit him in terms of involuntary Mental Health Act. Okay. For the long-term management, this patient, obviously, once he becomes stable, then we will send the patient to the community. Community mental health worker will regularly review the patient. GP will review the patient, and obviously, social worker will be there for anything with like any financial issues or center link support. Social worker will deal with that. There was MSc video cases. We will discuss this MSc video case in our role play session. There is a case of cockroach. I guess like whoever of you are dealing with the exam questions and everything, who knows how the questions are coming, you know that this is very popular cockroach case, which is actually a delirium case. We'll do role play with you about this case, then you will understand it. Okay. And remember one thing, in terms of this case is one of the, I would say one of the difficult case you will get in your exam. So patient all the time, they will say to you, doctor, there is cockroach in the room. Oh, there is a cockroach in your sleeve. There is a cockroach everywhere. So patient will only say cockroach, cockroach, cockroach. Everywhere there is cockroach. So it will be difficult. This is a delirium case, but also patient will show the tactile hallucination and visual hallucination of cockroach. They might have some delusion also. So it's an important thing that how to deal with these sort of patients. But let's do some role play, and then you guys will see that how to approach this sort of patient. We can deal with that in the role play session. There is one question in which patient comes with change in behavior. Behavioral change is all the time, like not all, most of the time, you will get it as a kind of psychiatric issues are there. So it could be mania, it could be schizophrenia. So we'll do these video cases also in our role play session. That's fine. There is one question which is university student. She has been previously diagnosed with schizophreniform disorder, did not take medication, now presenting with behavioral changes, take psychosocial history and present Msc, tell diagnosis differential. They have given 3 minutes for psychosocial history. Okay, so it will be hard. Don't bother asking everything. So I kept all the important things in here, but we don't need to discuss it tonight because I usually take a role play session as a role that just based on the MSc. So we'll do that first. I think the first 2 week session will be started from 21st of August. So we'll start with the MSc role play. Please try to go through this video in case you need some help. And then we will start the role play in our 21st August. That will be your first 2 week free session. Now, let me discuss about the course a little bit. Okay, there is a question, Dr. Urmi, to whom I should describe management in case of online exam. So online exam is, there will be role player in front of you. Examiner usually stays in the room, but you will never ever see the examiner and they don't talk to you. So in those cases, most of the time they don't ask you to do that. But if it is, then you will just address examiner and you will just give it to the examiner. Sometimes management even comes it to the patient. So whatever it is, you just act like you are doing it. You don't need to get any answer from examiner. So sometimes if they say that ask investigation from examiner will not talk to you. So when you ask investigation from examiner, the invigilator will give you the findings. Whatever investigation you are asking, invigilator will show it in the screen. So you just say, nothing else. Now, guys, the course is a 5-month course, and we start with a 2 weeks free session for everyone who is preparing for AMC clinical exam. Now, I guess like many of you might be already involved in any other course, and you may have paid a lot of money for those courses. But I would suggest, if you are not involved or enrolled in any course, go through this first 2-week session, find out how this course is helping you or not, because in 2 weeks, you will understand how we run course and you will understand everything. Some course will give you just one free session, and that's very unusual, and like anyone can take a very good class and if they're comfortable with just for particular one class, maybe they're best in that topic. But you can only assess someone if you take at least more than a week free session, and then you will understand, well, this might help me or not. It depends person to person that how you feel, what's your status at the moment, and how you want to help yourself with the help of this course. So decision is up to you, but obviously I would suggest to take the free 2-week session. Yes, you don't need to pay for this 2-week session, and payment starts after the first 2-week session. Okay. The online and face-to-face, we take both in our course. So we usually give you, when we discuss something, we discuss how you should approach for face-to-face and how you should approach if this is an online course. Initially, in the first few weeks class, we discuss about it, and then everyone knows that how to approach. So we don't give much time on approach later on. We give much time on our theory sessions, role play sessions. So that's why initial classes are very important. Remember, those who have already enrolled the course, there is a lot of you who has already enrolled in the course. So for you or who will be enrolling, this free 2-week session is included in your course. So please do not think that we will repeat the class again. Okay? So please make sure that you continue it. And Dr. Azmeri, please come to our first 2-week session. You will know how to ask this physical examination finding from examiner. Not tonight, sorry, okay? Because tonight we are discussing the mental issues, but obviously we will be having 2-week session and physical examination and everything. Please join those classes. You will find it. Now let me show you the video first, that what is included in the course and how it can help you, and then ask me questions if the video doesn't answer your question. Okay? Just hang on a second, please. So please have a look on the video. I will run it now. And then if you're still having any questions, feel free to ask me. Thank you. All right. So thank you so much for bearing with me. All right. So idea, the the course is a 5 months course. We take 3 days a week class. The classes at the moment we are taking on Saturday, Wednesday, and Tuesday. Saturday and Wednesday, the class is actually taken by me. And I usually take all the theory sessions and also all the, like most of the subjective role plays we'll do with you. Dr. Tasrifa, who is recently passed the clinical exam, she also takes a class on Tuesday. So she does all the recent role play, just only role play she's doing with our candidates. So there's a huge thing for every one of you. So you at the start you will get theories, you will get role play sessions every week. So that's a combination of, like, I can't say that how much important it is that from the start you know how to do role play, you know the theories, and as a combination it becomes a good preparation in 5 months. If you are very good with the 5 months, then I don't think you don't need to take more than 7 months as a whole for your preparation. Keep 2 months extra after the course just to wrap up what you have learned. But I would suggest that don't take more than 7, or at least take, if you are not sure, you can take 8 months, max 8, then start appearing the exam. Okay, some candidate I have seen, like they take like even 1 year, 2 year just to appear for the first time in the exam. No, don't do that, because it's like at the moment getting a seat in the exam is hard. And if you just wait, it will be long time. So don't wait, start preparation and appear the exam as soon as you can. Okay, because we discuss everything, and we usually will give you most of the cases that you want to know for appearing in exam. Your job is to just to prepare it and having a role player with you, so that you can do the role play with your study partner. For yourself, only thing that you need to do is to get a study partner. That also we will help you to find one, because in our course there will be a lot of candidates from different locations. Obviously, if you will be able to find someone. And this is how normally most of the candidate in our course get a study partner, just by asking or matching with their locations and time zones. We do the physical examination classes after 2 months of the course. And usually, like, there's a huge class, we take it for 1 month. We take 8 classes on physical exam for both face-to-face and online. Okay, and the recordings will be available even if you miss the classes, and everything is software based. So you'll be getting your notes, your recordings, everything will be in the software that we provide to you. Okay, and yes, it's 899 Australian dollar for 5 months, and you can pay in 2 installment, which half in first 2 months and then another half after 2 months. So that's how we actually taking courses. This is a highly recommended course for clinical, and it's not from my part. You can ask it from your fellow groups, and it's not only just from your fellow group. You can see it in the examinations, because every month 2-3 candidates are passing. And in terms of AMC clinical, that's huge, I would say, because we don't even get who is passing in the exam. Okay, so our success is consistent. Most of the candidate who appear it, they pass. And obviously, like, we can't guarantee that you will pass the exam, because no one can do that. And AMC clinical, it's not only just luck, it's a combination of everything. Your luck should be good, the cases that you have prepared, it should come in your exam. So it should be a combination of everything. And whoever is getting those combination, they usually pass the exam. And not to say that your approach should be better. Okay, I can show you how to make a better approach, but that inherent quality, you should get it by yourself. Okay, you have to follow what I'm saying, and if you follow 100%, I can say that, well, there is a chance you may pass the exam. Yes, Dr. Vondi, you can refer to the recording if you miss a class. We keep the recordings for a long, long time. So you can, even if you miss the class, you can get it. Yes, you get access to the videos of the class for 10 months. So there's a long duration. So 10 months is everything that you need to prepare the exam. PE is included in the 5 months course. Now, I know why you are asking this. So we actually also take the PE class for who are non-course students. Like most of you will be course students. Some candidates, they will not be included in the full course. They only wants to do PE course. So for them, we just allow them to join us for the 1 month PE class. Okay. But PE is included in your 5 month course. You don't need to pay extra for that. You don't need to register for the first 2 weeks. You can join just like today, but there is a free class Facebook group. I will give the link for that group in the Facebook tonight. Please join that group because the recordings will be uploaded in that group. And the class time is always 8 p.m. Sydney time. Yes, if your exam is very near, Dr. Kaur, like if you got an exam date, then you can join now. And what we can do for you, we can add you to our previous batch recordings. If you pay the full amount, then you will be getting the access to our previous batch recording. So you can finish it even 1 month if you want. And this is only for candidates who wants to appear the exam very soon. Like let's say our course is started on August and we'll be finishing on January next year. So you want to appear the exam on November. So we will not be able to finish everything by that time. What we will suggest, we will add you to our previous batch videos and you can access all the previous batch recordings in that way and you can finish your course in that way. And recordings has got everything just like a class, so it should be fine for you if you want to go for exam this year. Each class is 2.5 hours, and sometimes the role play session sometimes we go for 3 hours, but usually 2.5 hours. So 8 p.m. to 10:30 p.m. I haven't taken any course before. I am still new to this. I need some insight about the material that I must read. So the materials you need is only the course notes, nothing you need. Like AMC MCQ, there is a lot of books that you had to read, a lot of websites that you had to read, but clinical, only a course note is all that you need. Okay, and the videos you can get help from Geeky Medics for physical examination, but our physical examination class will be massive 1 month, so you can just get it from that. No need of reading Karen notes at all. There are some other notes, I think like some candidate also follow Marwan notes. So if you want to follow that, that's fine. That's okay. That means you need to follow notes which help you and which has most of the cages that you want. And you make your own note also. Like you take help from a couple of notes and then make your own notes. That's also good. And yes, the next class is only for the role play of these psychiatric cages. And if we finish early, then we will start something else. Any question? This course is not same for PESCI. If you're looking for PESCI, I would suggest like there are online courses for PESCI. Please refer to them. This course will not help you with the PESCI, but this course will help you with the approach. PESCI has similar kind of cages, but obviously you should you should get with someone who is only preparing for PSCI. I would suggest that, because you will just waste your money in this course, and again you will have to pay for someone who is doing PSCI. So if you are looking for PSCI, go to somewhere who is offering PSCI only. No need of buying anything before starting the course, but I would suggest before starting the course, start reading the clinical handbook. That must. Okay, please do that, and that is all that you need. And who asked about the P classes? P classes will be after 2 months. So if you're looking for near future exam, like let's say in 2 months time, send us a message that you want to join our course and you want to get an access for the physical examination class. So we can add you to our previous batch recording so that you can get to know with the PE classes. But in those cases, you have to pay the full amount before you get access. You will get all the course materials through our software, not through email. Okay, Dr. Farah. So when PE classes start, you will get the same 3 classes per week. 2 classes will be PE, 1 class will be role play, which Dr. Tasrifa will take, or anyone else. Handbook is must. Dr. Afrin, Ms. Paul, will this course also cover AMC clinical book? Yes, we discussed the clinical cases from handbook, those who are important. There is 150 cases in handbook. We can't do every cases which are not important. But I suggest at least give it a read by yourself. All the important cases from the handbook will be discussed. Formal course will start from 21st of August, Dr. Shobik. P class is physical examination, Dr. Alice. There, you will not get today's slide because this is a trial class, but once you are enrolled in our course, you will get into our course portal in the software, then you will be able to see it. So if you want to get enrolled now, just send us an email or send us a message in our messenger in the Facebook, and then we can start the processing. And then you will be able to look into the slides. You will get access to the slides until you pass the exam, okay? And it's only available in the software. Usually we start the course from 25th of August, Dr. Ahmed, but if your exam is very near, then send us a message that you already paid for the course and you want to get an access for the course materials. No, you will not get access to the software when you are taking trial classes. Only software access will be given after you are paid for the course. Okay, so because our software is only for our paid students and we give access to everything at the same time, so we can't allow you, and it takes a lot of time. So if you are not getting into the course, there is no need of accessing you into the software. Okay, it's just a waste of time. So if once you are paid, then you will be added to the software and then you can go through this again. And to register, send us an email or message. Okay, Dr. Josh. Yes, guys, software access will be there until you pass the exam. The notes are all the time you will be available to you. Excuse me. Any question, guys? So Dr. Rabia, we need to read systems and topics to be good on diagnosis and management as we used to. No, you just need to, we usually give you a cluster-wise approach. And that cluster covers everything that you know. Like we do a chest pain cluster, we go through the differential diagnosis and we do go through how to take history, how to take physical exam, and how to manage this patient. So in that way, you learn everything in a cluster. And cluster approach, like let's say we have a chest pain cluster and there are 5 to 6 cages in that cluster. And you just remember one format for chest pain and all those 6 cages will be covered using that same format. So in that way, you are making your preparation concise and you're not remembering every specific topic, which I have seen a lot of candidates are doing. And that's such a waste of time. And in exam, there is no way you will be able to remember 250 cages. But if we can make it in a cluster and make it concise, then you'll see that it's very easy to remember things. So we do it in that way. Cool. So I guess, I don't know if I missed someone's question. Please forgive me if I missed someone's question. You can ask me later in the course. That's fine. Okay. So let's finish it here tonight. We'll see you on 21st August, 8 p.m. Sydney time. Thank you all. Have a good night. Bye.